Everyone. It's a great pleasure to have an opportunity to talk to you all and to try to help sort out what is right now a very difficult time in the management of pregnancy and diabetes, in that we've got global conflict between simplified rules that are designed to identify as many babies as possible inside their mothers who are ultimately destined to become fat in utero, perhaps fat for a lifetime, versus what we can afford to do, what's best to do for mothers and babies. And I'm going to try to shed some light. I'm afraid I am not going to give you a final answer, but I will at least make you conversant with where these issues are pointing at the present time. So we'll talk about what's new in the diagnosis of gestational diabetes and type 2 diabetes, and review a little bit the treatment of gestational diabetes, what the benefits are, because they're definitely clear. The results of this really global trial for hyperglycemic outcomes from pregnancy, the HAPO trial, and how that was used to make some suggestions about a change and more unified approach to gestational diabetes diagnosis, and give you a little bit of preliminary data about what we've seen at UCSD since we started this process. I'm going to move through some of these slides rather quickly. You kind of know a lot of this stuff. I think we all know about the global obesity problem. The intensity of the color has to do with the intensity of the obesity, and the news is not that the United States is one of the darkest colors on the map. But what is interesting is countries like India, countries like China, South Asia, that have not had obesity in their past are now emerging. And Europe, similarly, you could pretty much depend on the Scandinavian countries to have very little obesity, and this is rapidly changing. So what happens? What is now happening globally is that we're becoming obese. In the United States, there are some states that are more likely to have obesity, as you can see again with the intensity of the color. But indeed, with the exception of Colorado and a couple of other states, I think Coloradans spend too much time hiking in the mountains to become obese. I'm not sure, but certainly there is almost no state that is not afflicted with up to 30% of the population or more in some of the purple states of the adults being obese. Of course, where obesity goes diabetes, and you can see the number of individuals and the percentage of the population diagnosed with diabetes, and this just takes up to 2008. You can see that big change in the curve that occurred in 1997, but indeed, I think when we get to see post 2005 or so, another cranking up verticalization of the curve is likely. Where diabetes goes gestational diabetes, and here you can see kicking us up to around 2004. You can see there's been a steady increase, and especially in the older women, who are shown in the upper curve. So we have more diabetes, more obesity as we get older, and that predisposes to gestational diabetes. Aging predisposes to gestational diabetes. So you could easily describe this as an avalanche of obesity and gestational diabetes that those of us who care for women in pregnancy are facing now, and will face even more in the future if we're not careful. Now, just a bit about type 2 diabetes, because I know that we thought we were taking care of healthy pregnant women who happen to get gestational diabetes, and once they deliver their baby in placenta, that diabetes is going to go away. Yes, in many cases, but finding gestational diabetes during a pregnancy is a marker for developing type 2 diabetes. In fact, the most commonly quoted statistic is that if you have gestational diabetes, medical treatment or not, during pregnancy, 50% likelihood of developing full-on overt diabetes within 5 years. I've got the criteria laid out by the American Diabetes Association up here for you to remind you that, that the diagnosis requires a fasting at or above 126, a hemoglobin A1C at or above 6.5, or if you happen to be taking the 2-hour glucose tolerance test, the 2-hour value over 200. Now, a random plasma glucose over 200 is not really diagnosis and needs to be repeated. So these are the criteria. You don't have to memorize them, but when we talk about what is now being recommended worldwide for diagnosing gestational diabetes, diagnosing type 2 at the start of the pregnancy, instead of in the past, we've always just said, oh my gosh, you've got diabetes. We don't, during the pregnancy, you appear to have diabetes. We don't know if you have type 2 diabetes or not because we just found you here at 28 weeks. But the American Diabetes Association is saying now, don't do that. Let's find out who's got type 2 diabetes at the beginning of the pregnancy. I'm guessing that most of the people who are listening here are not testing for type 2 diabetes at the start of the pregnancy, and you too are wondering about some of your patients. And of course, many of those patients, after they complete the pregnancy, don't come back for their 2-hour test, so we will never figure out until they come around pregnant again. Now, there's another category. If you remember, 6.5 is the definition of type 2 diabetes and a 126 on fasting. How about the people that clearly have abnormal hemoglobin A1C, clearly have abnormal fasting blood sugars, but don't fit into this criteria? Well, the American Diabetes Association calls this type or pre-diabetes. And, you know, it's kind of a troubling term. Now, people don't want to be told they have pre-diabetes, but in fact, somewhere between 35 and 75% of the individuals who have these results, either non-pregnant or in the first trimester, will in fact develop diabetes within the next 5 years. So regardless of whether you end up calling somebody a gestational diabetic later in pregnancy, if you have one of these numbers, you're in the pre-diabetes group. Now, management of prediabetes will be controversial during pregnancy, and we'll come back to that. So here are what the ADA recommendations are for the detection and diagnosis of gestational diabetes. And these came out in 2012 and have been affirmed for this year. And in fact, they match exactly the California Diabetes and Pregnancy Program recommendations. But I think most of the people in the room know that American College of OB/GYN and even the consensus panel from the National Institutes of Health have said don't go here. So this is what ADA says: screen for undiagnosed type 2 diabetes at the first prenatal visit for those with risk factors. And as I think everyone knows, all of us have risk factors unless you are under the age of 25, Caucasian, and thin. So those people, not at risk, but everybody else should be tested for type 2 diabetes at the first prenatal visit for the reasons we mentioned. They're obviously at higher, if they have those numbers, babies are at higher risk for congenital anomalies, need a different form of attention, and certainly should get early care. In the pregnant women not previously known to have diabetes, screen for gestational diabetes at 24 to 28 weeks. Now, there's a little change here from maybe what we've been doing in the past, where most people were screening 26 to 28 or even 28 to 30. And I'll come back and talk about the delays associated with that. But now it's recommended that you really screen around 24 weeks. The American Diabetes Association says use a 75-gram 2-hour test. We'll come back and talk about that in a second. So, sorry, let me take down to the next slide. So what to do with prediabetes? As I mentioned, the people who fall in the middle, we'll come back and talk about that. Now, here's one of the sticking points, because if you take the percentage of people in the United States who are presently diagnosed with full-on diabetes, it's almost 12% of the population. That's like 1 in 6. And prediabetes is usually twice the amount of people who actually have diabetes, which adds up to those with diabetes or prediabetes having almost a third of the U.S. population either already there with diabetes or having prediabetes. And people have said, well, that's too many. This is too many people with a disease. We can't manage this disease. We don't have enough resources to take care of this disease. We can't, this is what we have. And until we do something about our obesity problem, this is what we have to manage. So the argument that there isn't enough money to care for the people with diabetes and pre-diabetes, it's an interesting question. And it probably deserves a thoughtful answer. But the idea to legislate it out by changing the rules, maybe that's not such a good idea. Now this next slide shows the incidence of childhood obesity using the NHANES questionnaires that have been conducted by the government since the mid-70s. And we can all see that these childhood age groups, you see, ages 2 through 5 going up to the teenage group, that every year the NHANES is performed, more and more our kids are diagnosed with obesity. Not too surprising. But I think what is surprising is looking at this group over here on the left who are 2 years through 5 years. Already, 12% obese. That's shocking. And 2-year-olds obese. And I want you to think for a second. Is it possible that these kids are obese already because their mothers just don't know how to feed them, who give them candy and cookies and all these other things that should be limited in the diet, trans fats and so forth? Is it really about that? Or to what extent could it be that these children are already obese when they are born because their mother had gestational diabetes that maybe wasn't as best controlled as it could be, and they're not only fat to start and they continue fat, but they are programmed for fatness by their life inside the uterus. So we'll come back and examine that. Here's Michelle Obama, who's had a personal campaign on this obesity and the Move On campaign, and you can see that in 4-year-olds, almost a third of Native Americans are obese at age 4, and even in the Caucasian population, almost 16%. So the question is, are our children becoming fat because we overfeed them, or are they programmed in the womb? Well, here's an interesting study that was done in the Pima Indian population, and this was a very interesting cohort of women who were gathered who had 2 pregnancies. One when they for sure did not have diabetes, and a subsequent pregnancy when they did have diabetes. Now we took their siblings who were both born of the same mother, presumably ate at the same table, pretty much the same foods, and looked at the mean body mass index as they aged from children age 6 to 9 out in through the teenage and early adult years. The black bars denote the children their mother had diabetes in their pregnancy, whereas their siblings in the gray bars, their mother did not have diabetes. And you can see while there's little difference up to age 12, by the time the teenage years hit, there's almost twice as much obesity in the group who were exposed to diabetes when their mother had diabetes than if their mother did not have diabetes, suggesting that it's not about environment, diet, maternal fatness, genes, or if it is, it's only partly that. It may be also what the baby is fed in utero. This study right here, Charlotte Boney did in children around age 7, is similarly descriptive. So you look over here at the right. These are children born AGA appropriate for size, and their mother did not have diabetes or so-called control. This is the prevalence of the metabolic syndrome. Metabolic syndrome means hypertension, hyperglycemia, and obesity and hypertension. And you can see metabolic syndrome in children, and 7 or 8-year-old children. So you can see this is the likelihood if the mother has normal blood sugar during the pregnancy and the baby's born normally. Over here you can see that if the baby is born big, and most of these are fat big, but the mother has apparently no glucose abnormalities, being fat at age 7 to 8 is much more likely than it was if you were born normal size.